Thank you very much, Dr. Omar, for the nice introduction. It's becoming late a little bit. People are tired, so we'll switch gears. So maybe we'll relieve you from lymphoma now, and we'll talk about another lymphoproliferative disease, multiple myeloma. So I was asked to present updates on multiple myeloma. Unfortunately, there wasn't much of updates in the Lugano meeting, but I'll present what has been presented in the last ASCO in multiple myeloma. The multiple myeloma field is growing very fast, matching what is happening in the lymphoma, and as you could see, most of the updates are related to the use of bispecific molecules and CAR T cell therapy. So myeloma is not very far from that. So my talk, I'll present few abstracts, 3 or 5 abstracts. I hope I can cover within 20 minutes. So if I pass my time, you can just stop me at any point, please. So the first abstract is the long-term follow-up of the MajesTIC study, which is a phase 1/2 trial, and it was a registration trial based on which teclistamab, a bispecific molecule, anti-CD3, and B-cell maturation antigen, BCMA, on plasma cells, has been approved last October 2022. From the previous presentations of this trial, there was, after a median follow-up of 14.1 months, there was an overall response rate of 63%, and with a median duration of response of 18.4 months, and median PFS was 11.3. So this presentation is an update of the MajesTIC study, an extended follow-up at 2 years. This is the schema of the study. As you can see here, patients who are triple drug exposed to EMEDs, proteasome inhibitors, and anti-CD38 were randomized. The first one was the phase 1 escalation study, and then the phase 2 dose was 1.5 milligram subcut weekly, and then there was with a primary endpoint of overall response rate. This is how teclistamab is given, the first 2 ramp-up dosing, and then weekly dose of 1.5 milligram per kg. And there was an option after 6 cycles, 6 months of treatment, to switch to every 2 weeks or every 4 weeks, depending on the dosing schedule you are using, if patient achieved CR. These are the patient characteristics, 165 patients in the phase 2 extension study. And as you can see here, triple class exposed, almost all of patients, 100% of patients were triple class exposed. And refractory, triple class refractory, 77.6% of these patients were refractory to EMEDs, anti-CD38, and proteasome inhibitors. This is the overall response rate, still remains 63% of patients who have had a response. And as you can see here, it seems that this molecule works as all or none. So most of the responses here are VGPR or above. Only less than 5% of patients had partial remissions. Most of the patients who have responded had VGPR or above. CR rates were 45.5%. This is the progression-free survival for patients who have achieved CR and for all the group. The overall median overall survival is 11.3 months in the lower curve, In the upper curve, the green curve, which represents the group of patients who have achieved CR, the median progression-free survival was 26.9 months. Overall survival, again, based on both groups, it depends on, so the median survival for all patients was 21.9 months. Median survival, overall survival for patients who have achieved CR was not reached. Safety, toxicities, I mean, there wasn't really alarming as a bispecific molecule and T-cell redirective therapy, where T-cell activation happens, as you know. CRS was very common. Almost all patients developed some form of CRS, but almost all of them were grade 1 and 2 and manageable. ICANS were very rare. Only 5 patients developed ICANS, and they were all grade 1 and 2 and resolved. An alarming, probably, side effect was the rate of infections, where 80% of patients had some form of an infection. Again, grade 3 and 4 was happening in more than 55% of patients. And these infections were mostly respiratory, and there was 18 deaths from COVID-19, actually, within the trial, and respiratory infections was the most common. So that was for the MajesTIC. This was a small study presented again in ASCO, looking at the polyclonal immunoglobulin level in patients who were treated with teclistamab. As you can see here, okay, I mean, the amount of polyclonal immunoglobulin level goes down as you go down in the cycles. Reaching cycle 7, becoming very low, and that probably is causing the increased risk of infection in those patients who were treated with teclistamab. And since this study, the recommendation with teclistamab is to give IV immunoglobulin infusion every month for patients with low hypogammaglobulinemia. The second study I'm going to present is about talquetamab, the Monument Tal-1 results. Talquetamab is another bispecific molecule, CD3 and GPRC5D. GPRC5D is a target in plasma cells that is present in malignant plasma cells more than the normal plasma cells. It's also present in other sites, but in a very small percentage, specifically probably the skin and nails, and that's why, hence the toxicity of the molecule, which we will talk about in a little while. So in this phase 1/2 trial, which was previously reported, overall response rate of more than 70% across the 2 dosage forms, and overall response rates of 62.7% in patients who had prior T-cell redirection therapy. And this was the update that was presented in last ASCO. Again, the schema of the trial, refractory patients, again, patients who have at least 3 prior lines of therapy, and they have been exposed to EMEDs, proteasome inhibitors, and anti-CD38. So the trial is, there are 2 main groups. The upper 2 are more or less the same group, but different dosage schedules. This is the group where they had no T-cell redirection therapy, and this group is the group which they had T-cell redirection therapy, either a bispecific molecule or CAR T-cell therapy, and the primary endpoint was overall response rate. Baseline characteristics, the most important is probably the previous lines of therapy. As you can see here, they are all of them, 100% of patients were triple class exposed, and around 70% of patients in the 2 dosage forms. So the 2 dosage forms are 0.4 milligram per kg weekly or 0.8 milligram per kg every 2 weeks. There was around 150 patients in each group. And the prior T-cell redirection therapy, 50 patients, and most of these patients were actually, around 85% of those were triple class refractory. These are the results between the 2 different dosage forms and for the subgroup with prior T-cell redirection therapy. So overall response rate of about 72% in patients who have not been exposed to T-cell redirection therapy, and around 65% in patients who had previous T-cell redirected therapy. And again, most of the responses were VGPR. Specific subgroups, it seems that the drug is effective in most of the, all patients, whether they were refractory, triple class, and as you can see, the range here is between 70 and 80% in these different groups. In patients who had T-cell redirection therapy, as we had more triple class refractory, there was again 50 to 70% response rates. The median PFS was not reported, but it depends on the dosage form. So in the 0.8 milligram per kg every 2 weeks, after 12 months of follow-up, 54.4% of patients were still in remission. But in the prior T-cell redirected therapy, only 38.1 patients were still in remission. So probably median PFS is going to be around a year for this molecule. Median overall survival after 12 months is around 77% in patients without prior T-cell redirected therapy. The adverse events, there are unique adverse events for talquetamab, mostly because of the targeting molecule, which is mostly dysgeusia, which is related to taste. They have abnormalities in taste, and skin and nail changes that are very common, happening to more than half of the patients. Infection is there, probably in the, these are the hematological toxicities and infection. And infection, for infections around all grades, 3 and 4 infections occurred in about 59% of patients, and it led to discontinuation of the molecule in 1.4 and 2% of the patients. How am I doing? How many minutes left?
You have 7 minutes.
Oh, 7 minutes. Okay, good. So this is another study that combined teclistamab and talquetamab together, which is called Redirect TT1 study in a heavily pretreated group of patients. Again, the mechanism of action, teclistamab is CD3 BCMA, and talquetamab is CD3 GPRC5D. An escalation phase, and then the recommended phase 2 dose was 3 milligram of teclistamab and 0.8 milligram of talquetamab every 2 weeks. Just to draw your attention that these patients, many of these patients, around a third of these patients had extramedullary disease, and almost 90% of these patients were refractory to the last line therapy. 76% of the patients, 3/4, were triple class refractory. This is the hematological toxicities. Again, the toxicity profile is a combination of two. CRS is common, but it's mostly grade 1 and 2 and manageable. And again, specific toxicities related to the talquetamab, dysgeusia, skin toxicity, and nail disorders. Overall response rate in the phase 2 is 96%. But here, as opposed to what we have seen the previous two studies, half of the patients had VGPR or more, and most of the patients, again, VGPR or more. CR rates was 40% and 48% VGPR. Similar dose levels. The median duration of response was not reached at this point, and the median PFS was not reached. Again, after at this point of presenting these results in the last ASCO. Extramedullary disease, which is a unique entity that we know of, which is very hard to treat. As I said, about a third of patients had extramedullary disease, and it seems that the combination is effective in those patients. With the CR rates of about 28.6% and VGPR of 22.9. This is just a diagram of a patient who had lots of extramedullary disease that has been completely resolved after the use of this combination. Another combination, probably I'll just go over quickly, which is talquetamab and daratumumab, used in patients. This is the schema of the trial, talquetamab, daratumumab, in patients that were mostly refractory to anti-CD38. So the combination of daratumumab to talquetamab was tested in patients who were refractory to daratumumab, basically, in about 80% of patients who were actually refractory to anti-CD38. Overall response rates in the different dose forms, 84% in the phase 2, and showing a very good VGPR or more in 74% of patients. PFS, the median PFS is 19.4 months for this combination in the 0.8 milligram per kg every 2 weeks, which is the best PFS among all the bispecific molecules with this combination. The third molecule is irlanatamab, which is Pfizer molecule. By the way, talquetamab and irlanatamab were approved just last month based on these trials, which were updated in ASCO. So irlanatamab is similar to teclistamab, CD3 and BCMA. The trial is Magnetism 3, which has been reported previously. This is the schema of trial. Heavily pretreated patients randomized between there were two cohorts who had previous treatment with BCMA-directed therapy, and the other cohort were not. These are the inclusion criteria. So these are the results from the previous ASH last year. This is the doses, how it's given. So 2 ramp-up doses, and then every week, similar to teclistamab, but they have considered each 4 doses as 1 cycle. This is the patients. The patients here, among all the patients that I have presented so far, these are the hardest to treat patients. 96, almost all of these patients were triple-class refractory. So patient group is, very hard to treat, triple-class refractory, almost all patients.
1 minute.
So overall response rate, 61%. This is the previous presentation at 12 months, where only 58% were at remission. And then from ASCO, Mohammed Mati has presented this. So PFS at 18 months was almost 50-something, 50.4%. So PFS is beyond 12 months, 15 months. I mean, maybe the last report is 15 point something months PFS. I'll not go over this. I have CARTITUDE. You know, CARTITUDE is the cell-to-cell dual binding BCMA CAR-T. CARTITUDE has been presented multiple times, and in the last ASCO, it was the closeout results of CARTITUDE-1 was presented at 33 months. So just to go to the results, overall response rates almost 98%, and most of it deeper remissions. As you can see here, median duration of response 33.9 months, median PFS is 35 months. It's nothing to come close from bispecific molecules, but then we have to know how to sequence these drugs. With this, I conclude my talk. Thank you very much.